All right, well, good morning, everyone. Welcome, and I'm going to give you an overview today of pulmonary hypertension. So I'm Mike Cuttica. I'm a pulmonary and critical care doctor here at Northwestern, and I'm one of the co-directors of our pulmonary hypertension program. So as John said, approach to care in scleroderma and pulmonary hypertension in particular is requires a multidisciplinary approach. So we partner closely with John and Monique in the scleroderma program, and me and my partner, who's a cardiologist, Sanjeev Shah, are the directors of the pulmonary hypertension program. So we're going to go forward and we'll give you this overview of pulmonary arterial hypertension, which we all know is a complication that we see sometimes in patients with scleroderma. So we're going to define pulmonary hypertension, which can be, there's multiple different types of pulmonary hypertension. We'll talk about what we do to diagnose pulmonary hypertension, then we'll touch briefly on how we go about treating this disease. So what is pulmonary hypertension? Well, pulmonary hypertension is just high blood pressure in the blood vessels in the lungs. So just like we have a blood pressure that we measure in the arm, we have a blood pressure that's generated inside the lungs in the blood vessels. Normally, in normal physiology, the blood pressure inside our lungs is very low. So it's about 1/5 of what our systemic blood pressure is. So when we put the blood pressure cuff on our arms and we measure that blood pressure and we say, well, a normal blood pressure is 120/80 with a mean arterial pressure of like 75 millimeters of mercury, the pressure inside your lungs is normally very, very low. And normal average pressure in your lung, as we'll see in one or two slides, should be like about 14 or 15 millimeters of mercury. And there are many different things. When you develop pulmonary hypertension, that pressure in the lung rises. And there are many different disease processes that can cause the pressure to rise inside the lung. So when we get consulted for a patient with pulmonary hypertension, a lot of our initial evaluation is trying to determine, does the person actually have pulmonary hypertension? And if they do, what's causing it? So in order to understand this, we need to understand a little bit of the anatomy that we're dealing with here. So this picture is a schematic that looks at our cardiopulmonary system, the heart and the lungs, and they've split the heart into the right side of the heart and the left side of the heart. The right side of the heart is the part of the heart that takes all the blood that comes back from the body. That blood passes through the right atrium, goes into the right ventricle, then gets pumped out into our pulmonary artery, and that pulmonary artery carries all the blood into the lung. This picture here is a schematic of the lung parenchyma or alveoli in the lung. The job of the lung and the blood vessels is to get oxygen into the blood. As that oxygen-rich blood then drains out of the lungs, it goes into the left side of the heart, into the left ventricle, and then gets pumped out to the body. So when we measure the blood pressure in your arm, that's the blood pressure that the left side of the heart is generating every time this muscle squeezes and pushes blood out into these blood vessels going out to your body. Every time the right ventricle squeezes, it generates a blood pressure in that pulmonary artery. So what are the normal numbers here? Well, a normal pulmonary artery pressure is like 20/5 with a mean pulmonary artery pressure less than 25, or a normal is about a mean pulmonary artery pressure about 14. And as we said before, that's as opposed to our systemic blood pressure that's usually 120/80 with a mean of around 65 or 70. So a very low pressure, low resistance system inside the pulmonary vasculature under normal conditions. So when we talk about pulmonary hypertension, it's this rise in the blood pressure inside the lung, we need to think about the different things that cause it. So pulmonary hypertension is actually an umbrella term. There are actually 5 different types or classes of pulmonary hypertension. And it's important to at least have a little bit of an understanding of this. So as we approach a patient with the diagnosis or the potential diagnosis of pulmonary hypertension, our first order of business is to try and figure out what type of pulmonary hypertension a patient may have, because that really figures into prognosis, into therapy. It's a very important question. So this is the Dana Point 2008 classification scheme of pulmonary hypertension, and what we're all familiar with in scleroderma and what we all worry about is this class 1 pulmonary arterial hypertension. That's what we're going to mainly focus on today. But we know this is a rare disease. In scleroderma, it occurs in about 9% of scleroderma patients, but in the general population, pulmonary arterial hypertension is like maybe 5 cases per million people in the population. So it's a rare disease and a less common complication of a rare disease when we talk about scleroderma. Much more commonly, what we see even in the scleroderma patient population is class 2, which is pulmonary hypertension that's caused by left heart disease, like if you've had a heart attack, or if you have valvular disease in the heart, or if you have what we call diastolic dysfunction where the heart has trouble relaxing. It can mess up the flow of blood, and blood can back up into the blood vessels in the lungs and cause the pressures to rise. Pulmonary hypertension, class 3 pulmonary hypertension is when patients have lung disease like scarring in the lungs or emphysema, and the pressures can rise because of destruction of lung tissue. And we see that in scleroderma with patients that develop interstitial lung disease. Type 4 is when people get a bunch of blood clots inside of the lungs, which can happen in scleroderma but is less common. And then type 5 is this kind of grab bag of some miscellaneous diseases. But what we're going to focus on mainly today is class 1, because whenever a scleroderma patient is told, oh, we're worrying about pulmonary hypertension, and you like go on the internet and Google pulmonary hypertension, this is what you read about. And this is the complication that we really worry about in scleroderma. So class 1 pulmonary arterial hypertension, the disease of the blood vessels in the lungs, there's many different types, but it's the associated condition is it's associated with connective tissue diseases. And of the connective tissue diseases, the most common disease associated with pulmonary arterial hypertension is scleroderma. So the other way to think about these different classes is to think about, well, where in the cardiopulmonary system is the disease process that we're dealing with? And this is important for understanding how we treat people and how people may react to some of the drugs that we put them on if we misdiagnose them or treat the disease that's not, or treat a different type of pulmonary hypertension with pulmonary arterial hypertension therapy. So this again is a schematic with the right side of the heart here, the pulmonary artery going out into what we call the capillary bed inside the lung where the exchange of oxygen occurs, then the pulmonary venous system going into the left side of the heart. So in class 1 pulmonary arterial hypertension, this is really a disease of the very small blood vessels right before you get to this capillary bed inside the lung. This used to be called precapillary pulmonary hypertension, but it's really the very tiny blood vessels that are primarily affected. So things like CT scans where we're taking pictures of the lung really can't visualize the size of the vessels that are diseased in class 1 pulmonary arterial hypertension. In class 2, it's really a heart problem in a venous side of the pulmonary circulation where blood is backing up and filling up these blood vessels in the lungs, engorging them with extra fluid. And as you put more fluid into a tube, these blood vessels, the pressure rises. In patients that develop class 3, it's really a destruction of the lung tissue, and as you destroy the lung tissue, these capillaries or very tiny blood vessels get destroyed, so you can't get the exchange of oxygen well inside the lung, and the pressure rises. And then in patients that develop chronic thromboembolic disease or lots of blood clots in the lungs, it can affect anywhere from the main pulmonary arteries all the way out to the very tiny blood vessels. But again, we're going to focus mainly on type 1 or class 1 pulmonary hypertension affecting these very small blood vessels. And then the class 5 really is determined to be class 5 because it can cause pulmonary hypertension through any of the different mechanisms. So this slide just is highlighting one important point which is in order to make this diagnosis of pulmonary hypertension, we really need to measure the blood pressure inside the lung. This disease is defined by the measurement of the blood pressure in the lung. And as we go forward, you'll see really the only way to do that is through a procedure called a right heart catheterization. So these numbers aren't important other than to say that when we measure type 1 pulmonary hypertension, we're looking for an elevated average pressure in the lung, higher than 25 to make the definition of pulmonary hypertension. And specifically for type 1, we want to see that the pressure on the left side of the heart is normal. And why is that important? Well, it's this concept of resistance to blood flow that becomes really important in pulmonary hypertension. Because we said the pulmonary circulation is usually a low pressure, low resistance system. When people develop pulmonary hypertension, what we worry about is this, it makes it very hard for the heart to pump blood through the lungs. So this is, basic physics. The Ohm's law, which is the resistance to flow of a fluid is determined by the change in pressure divided by the flow. So we measure the pressures on the right side of the heart, we measure the pressures on the left side of the heart, and then we divide it by the flow, which is how much blood your heart is pumping in liters per minute, and we can determine what the resistance to blood flow is through the lung, and that really is what determines the type of pulmonary hypertension that you have. So in scleroderma, when we talk about type 1 pulmonary arterial hypertension, we want to know what are the things that can cause this disease. Well, we really We really think there are 4 things that drive this disease process. So number 1 is vasoconstriction, which really means that the blood vessels in the lungs clamp down. So our anatomy, our cardiopulmonary system is a very elegant and complex system that is able to respond to our demands that we put on the body. So when we go to exercise and we need to get more blood pumping out to our muscles, the heart is very good at pumping more blood, and the blood vessels in the lungs are very good at accommodating that increased flow of blood by dilating and constricting down to kind of control how the blood passes through the lungs. When patients develop pulmonary hypertension, we lose that regulatory mechanism, and the blood vessels kind of skew towards this constriction. So as you can imagine, as these blood vessels constrict down and clamp down, it makes the pressure go up. And we know that some of the chemicals in our body that regulate this dilation and constriction of blood vessels in the lungs get thrown off in patients that develop pulmonary hypertension. So we underexpress things that dilate the blood vessels, like nitric oxide and prostacyclin, and we overexpress things that constrict the blood vessels, like endothelin. And these 3, there are probably multiple other mechanisms that drive this, but these 3 are important because these 3 mechanisms, or these 3 chemicals, are the targets of our therapy for this disease. So vasoconstriction plays a role, and you're related to vasoconstriction, and as the disease progresses, we get this remodeling or an anatomic change to the blood vessels in the lungs, which we'll see pictures of on the next slide. We get some blood clotting going on in the lung, and then in the blood vessels in the lungs, and then we know that inflammation plays a role because there's lots of inflammatory cells that go in and surround these blood vessels. But these are really the 4 things that are thought to drive the disease process. So, and they're important because this is how we target therapy. So we try and dilate. Sometimes we'll talk about putting people on blood thinning medications for this. And what we really lack now and why we can't cure this disease is we don't really have a good way of fixing the remodeling or the changing of these blood vessels. So what is remodeling of a blood vessel in the wall? Well, this is what happens inside the blood vessels of patients that have pulmonary arterial hypertension. So this is a normal pulmonary artery. This is a blood vessel passing through the lung that they've cut in section here. And you can see this is what we call the lumen. This is where the blood actually flows through. And you can see a nice big wide open hole here with lots that blood can easily pass through. There's a little bit of, this area right here is a little bit of muscle that surrounds the blood vessel that helps the muscle contracts and relaxes to help the blood vessel close down or open up. So when people go on to develop pulmonary hypertension, what we see is you get an increase in muscle deposition around the blood vessels in the lungs, and that kind of tends to narrow the lumen inside the blood vessel. And you get this abnormal growth of cells, so endothelial cells, which are the cells that line these blood vessels. They should be a single layer of cells that line the inside part of this blood vessel. They start to grow abnormally, and these abnormal cells grow out, and really you can see this diseased and abnormal blood vessel, and you can imagine as these cells grow and the muscle cells grow, you get an encroachment on this lumen, and as that lumen gets narrower and narrower, it's harder for blood to pass through, and it increases this resistance to blood flow. This is a blood clot sitting in one of the blood vessels in the lung. So you can imagine as the disease progresses from normal blood vessels to this is what's driving that remodeling and driving that increased resistance to blood flow going through the blood vessels. So how do patients present? How do we know when someone's developing pulmonary hypertension? Well, it's a very non-specific presentation. Usually patients, the most common thing that I see in my clinic is people come in and say, you know, over the last 6 months to a year, I've just been getting more and more short of breath. It's this progressive shortness of breath. You know, a year ago, doc, I could walk 4 or 5 blocks. I could take my dog for a walk and have no problems. And now over the last year, I get to the point where every time I get up to go to the bathroom, I'm winded and I can't do anything without being short of breath. So this kind of progressive breathlessness is one of the main signs that we see for the presentation of pulmonary hypertension. But that's a pretty non-specific sign. I mean, people get short of breath for lots of reasons. You can have asthma, COPD, lots of different things that can lead people to be breathless. Fatigue, weakness, pain in the chest, swelling in the legs is always a sign that there's potentially something bad going on. And then certainly if someone passes out, that's a sign that, you know, we really need to be concerned about pulmonary hypertension. So, you know, we need to have a high clinical index of suspicion for pulmonary hypertension, and That's why in scleroderma, it's so important that we screen for this disease on a regular basis, because we know that in this rare disease, pulmonary arterial hypertension, we know that the scleroderma patient population is a high-risk patient population. So we need to screen for pulmonary arterial hypertension to try and identify it early. So these kind of nonspecific and subtle signs need to trigger us to be looking for this disease in patients with scleroderma. So why do patients with scleroderma who develop pulmonary arterial hypertension get short of breath? Well, as we talked about in the previous anatomy slides, the main job of our lungs is to provide oxygen for our body so that we can meet our physical activity needs, right? Oxygen is used for energy in meeting our activity needs. So the oxygen in our lungs enters from the blood through these tiny little blood vessels called capillaries that surround the air sacs that are called alveoli. It's another schematic showing the alveoli, and then these tiny blood vessels. As the main blood vessel leaves the heart, it kind of branches like the branches of a tree all the way down to these tiny little blood vessels called capillaries that are like the twigs on the end of a tree limb. And then as the blood passes through these capillaries, these tiny little blood cells actually pass in a single file line right next to the alveoli, and you get this exchange of oxygen. So if you have pulmonary arterial hypertension, it gets harder for the blood to get into the lungs and to reach your lungs and be able to pick up oxygen. You go from these healthy blood vessels to these narrowed down diseased blood vessels. The resistance to blood flow goes up, and it makes it harder for blood to get there. The heart has to work harder and harder and harder to push blood through the lungs. And over time, this increased resistance to blood flow puts a strain on the right side of the heart, as it's having to work harder and harder, and we'll see changes to the right side of the heart related to these changes. And you can imagine, as it gets harder for the heart to deliver blood to the lungs and harder for blood to get into the lungs and pick up oxygen, it gets harder for you to deliver oxygen to your body. So when you get up to try and go up a flight of steps or walk down the street and you get short of breath, it's because you're not able to meet the demands that your body needs in order to do that physical activity. So like we said, we see right heart strain. As this resistance to blood flow increases, the right side of the heart, which is normally kind of a small, weak muscle that never has to work very hard to get blood to go through this low pressure, low resistance system in the lungs, all of a sudden this right heart is having to push and push and push to get it through these diseased blood vessels. And over time, we see the right side of the heart dilate or enlarge. We see the function of the muscle decrease, so we see the muscle not able to squeeze very well. And then we get this decreased oxygen delivery that leads people to feel short of breath and fatigued. So that then leads into, well, how do we diagnose this disease? It's rare. The presentation is not very specific with the symptoms that people complain of. So typically to make the diagnosis, we undergo a series of tests to determine if you have pulmonary hypertension or some other illness that may present similarly to pulmonary arterial hypertension. And we really making this determination and determining what type of pulmonary hypertension is really important for deciding how we're going to treat you. So the primary tests that we look for, that we use, mainly are for both screening purposes and then following people that are given this diagnosis over time, are the ultrasound of the heart and the pulmonary function testing. So these are the cornerstones of the tests that we use in our scleroderma population, in our pulmonary hypertension clinic, to screen patients with scleroderma for the onset of pulmonary hypertension so we can identify it early and get it treated. The ultrasound of the heart, or the echocardiogram, and the pulmonary function testing. So an echocardiogram is just an ultrasound picture of your heart. It uses sound waves to take a picture of the heart, and it allows us to get a picture of the size and the function of the heart muscle itself. It gives us this useful information on the structure. And we can provide an estimation of the blood pressure in the lung. And I'm sure you guys have been through this and seen this with your echocardiograms, but that number that we get on the echo is an estimation. It's prone to error. We can overestimate, we can underestimate. Sometimes we can't even get that estimated number. So the echo is important and that number is important, but much more important on the echocardiogram is this picture or the description of the size of the right side of the heart and the function of the right side of the heart. And that's what we really use to rely, one of the things we really rely on for doing both screening purposes and and for following patients after we've made the diagnosis. So I don't know if this is projecting well, but this is a snapshot picture of an echocardiogram of a patient with pulmonary arterial hypertension related to scleroderma. And this is, our heart is a 4-chamber structure, so we've got atria that are down here and the ventricles that are pumping blood into the lungs and out to the body here. And what we see here on the right side of the heart is that the right ventricle is gigantic. The right atrium is gigantic. It's kind of so big that we get the left side of the heart is being crushed by this right side pushing over. So this is a sign of someone that has very severe right heart strain from this resistance to blood flow through the blood vessels in the lungs. So pulmonary function testing is also one of the key tests that we do to screen for pulmonary hypertension in scleroderma patients. So pulmonary function testing tests 3 things. Spirometry is telling us how well does air flow in and out of your lung. The lung volumes tells us how much air do you actually have in your lung. And then this test called your diffusing capacity of carbon monoxide tells us how well does oxygen go from your lungs and into your blood. And this is an important test because what this does is looks for both pulmonary arterial hypertension, but it can be an early screening test too for other complications in scleroderma like scarring in the lungs, the interstitial lung disease that we see sometimes. So we'll look for, is the total volume of air in your lungs low, which is what we may see in patients that are developing scarring in the lungs. We'll look for things like, could you also have some emphysema or asthma when we look at flow? But in the setting of pulmonary arterial hypertension, what we're really looking for is normal flows, normal lung volumes, and really an isolated reduction in the diffusing capacity, saying, hey, there's something wrong with the blood vessels in the lungs here. So either an isolated reduction, or if over time, as we do screening tests, yearly screening tests with pulmonary function, if we see this diffusing capacity dropping and everything else staying stable, that can be a sign that, hey, we should be thinking about pulmonary hypertension here as a diagnosis in this patient. Those are both great screening tests. Echoes, pulmonary function tests, we use those for screening purposes, and we use those for following patients after we've made the diagnosis. But really the gold standard for making the diagnosis of pulmonary hypertension, so a scleroderma patient that comes in with progressive shortness of breath, who has an abnormal echo, who has an abnormal pulmonary function test, and we say, we really think this person is developing pulmonary hypertension. The gold standard test for making this diagnosis is a right heart catheterization, because this is really the only test that allows us to directly measure what is the blood pressure in the lung and give us some very useful information about what's causing the pressure to be high, which type or which class of pulmonary hypertension do you have, and then giving us prognostic information to say, how aggressive do we need to be in treating this patient? How advanced is the disease when we make the diagnosis? So it is absolutely necessary before the initiation of any pulmonary hypertension specific therapy. We generally say you should not be on any pulmonary hypertension medications unless you've had a right heart catheterization, because misdiagnosis and mistreatment treating class 2 pulmonary hypertension like class 1 pulmonary hypertension can really lead to harm in patients. So the right heart catheterization is key in making this diagnosis and knowing exactly what it is that we're treating. Like I said, this is the only test that really allows us to measure the pressure in your lung, and it allows us to calculate how much blood is your heart pumping every minute, and actually calculate that resistance to blood flow through your lungs, so we can get an idea of how hard is your heart having to work in this disease state, and then that lets us know how we should treat people. So the right heart catheterization sounds horrendous, and when I sit in my clinic and I explain this to patients, I'm like, oh my God, I can't believe that anyone ever allows us to do this test. But I tell you, with every patient, after I've described it to them and I say, oh, but don't worry, it's really not that bad, without fail, every time I go and we do the catheterization, I talk to the patient afterwards, probably 99% of the time they say, you know what, that was so much worse in my mind than it was in practice. But it's really not that bad of a test. It sounds horrible, but basically the gist of it is we insert a thin catheter through an IV. The IV goes into one of the large veins, so typically we'll put it in the neck, in the right side of the neck. That gives us the straightest shot into the heart. Occasionally, for anatomic reasons, or if there's some reason we can't go in the neck, we can also put the IV into the vein in the groin. But we put a large IV into the neck or the groin, then we take this long, thin plastic catheter that threads through that IV, it comes down, it goes through the right side of the heart, through the right atrium and the right ventricle, up out into the pulmonary artery and then sits right in these arteries right inside the heart. And through that catheter, through a static column of blood, we can transduce a pressure. We inject some saline to measure or salt water to measure the cardiac output. And it really does give us all the information we need to make this diagnosis. We say that typically a right heart cath, you can expect it to last about an hour, but in practice, most of the time a right heart cath, when it's just a right heart cath to make the diagnosis of pulmonary hypertension, really only lasts about 20 minutes with the catheter in place. We get all the information we need within 20 to 30 minutes, but from beginning to end, from when you go in on the cath table and get prepped and have the catheter and done and back out into recovery is about an hour. Occasionally, an additional catheter will be inserted into the artery, what we call a left heart cath, if we really need to measure what the pressure is on the left side of the heart. So we'll see in the next slide where we measure these pressures. But when we make the determination on a right heart cath, we're really trying to decide, is this class 1 or class 2? So the pressures on the left side of the heart become very important. And we can estimate the pressures on the left side of the heart from a right heart cath. But if the estimation looks bad or we can't get the answer we need, we'll occasionally insert the catheter into the artery as well and measure the pressure directly on the left side of the heart. We also do other testing during a right heart cath. Sometimes we have you inhale a gas to see what happens to the blood pressures in the lungs when we give you this gas. Sometimes we give you medications through the IV to see what happens to the pressures in the lungs. Sometimes we just give you fluid boluses like the normal saline to see what happens. So there is a lot of testing that can be done on the right heart cath and just a wealth of information that we gather to really tell us what exactly are we treating here. So again, we think about what the anatomy is. Well, what we do on the right heart cath, you can see in this picture, this is actually a picture of a Swan-Ganz catheter or a right heart cath that passes through the right side of the heart out into this blood vessel in the lung. We measure pressures here in the right atrium. We measure the pressures in the pulmonary artery. We measure the pressures on the left side of the heart if we need to. But really one of the keys that I was alluding to before is this balloon that is at the tip of the catheter, that we are able to inflate this balloon and wedge it into this blood pressure, into this blood vessel, and then we can get what's called a pulmonary capillary wedge pressure, which estimates the pressure on the left side of the heart. If this wedge is not accurate or we can't get it, that's when we put the catheter into the artery and measure the pressure on the left. So that's a right heart catheterization. Is really one of the key points of this talk is to say this is the diagnostic test of choice, the gold standard that we need to make this diagnosis. So other tests that might be ordered in the workup of this, well, most people will end up getting an EKG, just one of those, put the pieces of probes on the chest, the sticky tape on the chest, and measure the electrical conduction inside the heart. This can give us some idea of, is the right heart under strain? Almost everybody or everyone should have a CT scan of the chest to look for fibrosis in the lungs or to look for blood clots in the lungs in patients with pulmonary hypertension. This VQ scan is a scan that we do that is specifically looking for blood clots in the lungs, so we want to be ruling out that type 4 pulmonary hypertension. And then a lot of times we'll get a sleep study to see, if you have pulmonary hypertension, is your sleep affected by it, meaning like do your oxygen levels drop at night? And then we also want to make sure, since sleep apnea is a common problem and sleep disorder breathing, make sure that you don't have sleep apnea, which can cause that type 3 pulmonary hypertension. So, the tests are not that important. The specifics of which tests we order aren't that important, but the reason I highlight these is that really the workup and the tests that we may talk to you about and what we need to do are really designed to delineate which class of pulmonary hypertension you may be in, and to look for risk factors for the different classes, because we want to really know what type of pulmonary hypertension do we have before we treat it. So the last couple slides, I'm just going to talk about how we treat pulmonary hypertension. So really the goal of treatment is to make people feel better. We can't, unfortunately, at this stage, cure this complication in scleroderma. We cannot cure pulmonary arterial hypertension with the drugs we have available. Lots of research going on, lots of new drugs coming down the pike. There's actually just a drug approved last week, a new drug with a new category for treatment of PAH. So hopefully in the years to come, we'll have a cure for pulmonary arterial hypertension, but right now we don't. So our goals are really to relieve symptoms and make people feel better. And the way we do that is to take the strain off of the heart by affecting the blood vessels in the lungs. So our initial treatment decisions, most of our drugs all of the drugs that we have now are really designed to focus mainly on that vasoconstriction. We give drugs that dilate or open up the blood vessels in the lungs by targeting those 3 pathways that we talked about. So our initial treatment decisions are really based on how far along has the disease progressed and how symptomatic is a patient when they are given this diagnosis of pulmonary arterial hypertension. And as you guys probably know, we have lots of treatment options now. This is a really interesting disease in that before 1996, we really had no pH therapies, specific therapies for pulmonary hypertension. In 1996, we had one of the first pH specific trials that were done, and we got a drug category that was used to target pH. In the late 1990s, we had Flolan or epoprostenol approved, and since then there's been an explosion. We have about 15 drugs on the market now that are available for treating this disease, all in those three categories. But our treatment options range from pills, oral therapy, just pills that you take once a day or up to three times a day. We have a couple inhaled therapies now that some of you may have seen or talked about with your doctors. And then we have the kind of backbone or the most powerful or potent drugs we have to treat, which are the continuous IV or subcutaneous infusion of the prostacyclins there. So lots of treatment options from a medical standpoint. And again, which of these if we start with pills or start with inhaled therapy or start right off with the most potent kind of infusion therapies is really determined by how far along is the disease progressed at the time we make the diagnosis. And as of right now, I put this last one up here as just a highlight that we can't cure the disease. Right now, the only cure we have for pulmonary arterial hypertension is lung transplant. So we do talk about transplant in patients, even in our scleroderma patients, as the disease progresses. But thankfully, I think in the last 10 to 15 years, the number of patients with PAH that get lung transplants has been declining for various reasons. But one of them is our drug therapies that we have help to keep people stable longer so that they have less of a need for transplant. But we do discuss lung transplant as this disease progresses as a potential cure for the disease. So this is just a picture. This is from a New England Journal of Medicine article in 2004. And it seems like no pulmonary hypertension talk is complete unless you put this picture up here, because this highlights the different pathways that we use that we had talked about before. So this is a schematic or a picture of a cross-section of a pulmonary artery, and we just say the three main pathways that we know are affected are the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. So nitric oxide and prostacyclin dilate blood vessels. That's underexpressed or underproduced in patients with pulmonary hypertension. Endothelin constricts blood vessels, and that's overproduced in patients with pulmonary hypertension. So our treatments are really designed at blocking endothelin. So these are drugs like bosentan and ambrisentan. And there's another one that is coming on the market soon, I think, but that's blocking the endothelin pathway. We give drugs to try and increase the production of nitric oxide. So these are our phosphodiesterase inhibitors, which are drugs like sildenafil and tadalafil that are approved for therapy for PAH now. And then the prostacyclin pathway is giving our infusion therapies or the inhaled therapies. So these are drugs like treprostinil or epoprostenol or iloprost are the drugs that we use to target this pathway. So we try and dilate the blood vessels with these drugs and block endothelin to prevent vasoconstriction. So I'm just going to conclude by saying pulmonary hypertension is just high blood pressure in the lungs. Patients with scleroderma are at an increased risk for developing this complication, so active screening is very important, and we screen by yearly echocardiograms, yearly pulmonary function tests, and then there's some lab work that we use occasionally to screen for that as well. The diagnosis of this disease is made by excluding other causes of the symptoms and by the right heart cath. So looking for other things that can make people short of breath, looking for other things that can cause the other types of pulmonary hypertension, and then ultimately ending in the gold standard test, which is the right heart catheterization. And really to end on a positive note, and it really is true, there have really been some great advances in treatment of this disease in the last 10 to 15 years, and multiple new drugs being studied and multiple new drugs coming on the market even in the next couple of months. The one that was approved last week, there's another one that is pending FDA approval right now, which we're anticipating in the next couple of weeks that are going on. So great advances, and really these great advances that have been made in the 10 to 15 years have been due to programs like the Scleroderma program and the Pulmonary Hypertension program here at Northwestern that kind of pushes research and patient-centered care, and things like the Scleroderma Foundation and the Pulmonary Hypertension Association that are really well-organized patient advocacy groups that kind of allow us to to study this disease and study the treatment so that we can really lead in, instead of talking about treating people to make them feel better, we can start talking about treating people to cure the disease and get them back to normal. So with that, I'm going to stop, and I thank you for letting me come and talk to you guys today.